Hi, everybody. Uh, as classes were canceled because of the power outage, I'm doing the dictation now for both Section A and Section B. They're identical because we're at the exact same place. So this is April 30th when we're supposed to have class, and so make sure you get a chance to listen to this. I'm going to try to focus. This is female reproductive. I'm going to try to focus on specifically what I know to be on the final exam, so you can see. Really, that's the purpose of all this. And I don't think I'll be able to finish it all, but we'll get most of it in. I'll probably spend Friday afternoon maybe reviewing the cycles because I think that's really a critical piece to understand. But and again, I'm using the Marie PowerPoints for these rather than the Welsh Hole ones, just out of convenience. I think these are really well done, so good enough with that. And here it is. This is 26B. As you can see here, my voice goes is because I've been going a little bit as we get to the end of the semester. And so the one thing that is universal for both is that axis, the GnRH and the FSH and the LH. And in the male, it was testosterone and inhibin, and in the female, it's estrogen and progesterone and inhibin. You must remember that and the things that they do. I can't stress it enough. FSH, follicle stimulating, in this case, is going to mean eggs and egg development. LH, luteinizing hormone, is going to mean production of estrogen and progesterone and plays a pivotal role in ovulation. And that's part of what we're going to be dealing with. The female reproductive anatomy is straightforward. I don't think if there's any anatomy, it is minimal, other than maybe some things that could go wrong or where fertilization occurs in from the anatomical perspective in this chapter, as opposed to the physiology, which I think is relatively simple in the male. I'm very complex here because we're going to find out we've got two cycles to deal with. We have an ovarian cycle and a menstrual cycle. What controls them? Thankfully, I think the slides will tell the tale fairly easily if you take the time to look at them, please. So again, the primary structure is the ovaries, estrogen and progesterone. It doesn't matter. I just call them estrogen and progesterone rather than their quote unquote active forms. It's an internal system as opposed to an external system. That's anatomy. There's not a whole lot else to say about that. The significance is here. It's the relationship, the fact that we're in such close proximity to the, the rectum and to the anus, to the vagina and the urethra, and they're all separate structures, but the proximity creates really problems vis-a-vis infection. And the part I will certainly get to on Friday is aspects of infection, which will sort of reinforce what I'm doing with my micro class, undoubtedly at the same day. So, I mean, this is the anatomy. The ovaries are where they are. That's an anatomy question. The ligaments, that's an anatomy question. All those things. The interesting thing about them is when you see the illustration, and we'll get to that, understanding here is the ovary itself. And interestingly, the medullary area the core is where blood vessels and nerves and lymphatics are. The egg develops along this cortex, sort of starting here and working its way around and basically ovulating out somewhere around here, as you will see. So, again, that's part of the thing that we're going to be looking at with regard to what's happening here. So I will continue on. So I'm just trying to give you a little bit of context. And the point I was trying to make, I'll get over here and I'll flip back. With all of those structures, they effectively, unlike the male, here it's a good sized area, and all of these structures are interlaced. What they call the broad ligament here, the ovarian suspensory ligament here, the ovarian ligament here. All of these structures are supportive of the tubes, the ovaries, the fimbriae, all of these things. And the problem is when they get infected or inflamed, the whole system responds as infected and inflamed. And we'll get to it at the end. It's called pelvic inflammatory disease. It is a nightmare. And this is typically something we see late stage with genitourinary infections, particularly of the sexually transmitted type. Rarely something that had a bacterial origin, other than may have perhaps something that had to do with a significant disease or cancer. So PID is the acronym, and you'll all hear about it if you haven't heard it about already. Pelvic inflammatory disease. It is a bear. What it means: ectopic pregnancies, early hysterectomies, remarkable degrees of infertility. Nothing good. So, blood supply, ovaries, just like the have the gonadal artery. In the male, it goes to the testicles. Here, it goes to the ovaries. Okay, there's a tiny branch of the uterine artery. The uterine artery, you might remember, comes off the thank you, comes off the internal iliac artery, and that's going to be the critical artery. This dog is getting on my nerves. This is in the bedroom with me. That's the critical artery for it has to do with menstruation. As you will see as we get down there, the uterine artery is going to it comes off the internal iliacs, and eventually, as it gets to the uterus into that area, it forms two different sets of arteries. One is called one are called straight arterioles, and the other are these spiral arteries or arterioles. We'll get to that when that's coming. Again, similar to the male, we have that white heart external area, the albuginea, and again, we have a covering with peritoneum, which is really the tunica vaginalis. Again, I think that's more anatomy than physiology, as we said to. And here it is, the follicles and all this type of stuff. And I'm not going crazy about it. That's there. The point number one. Unlike the closed system in the male, where the sperms make their way along and are never really exposed to anything, any other tissue, the bloodstream, lymphatics, because we know about the fact that your immune system would attack them in the male if they are exposed. That's why we have that testicular, that blood testicular boundary or blood test barrier is the way that they describe it. Here it does not exist, and the reason is women are born with all of the eggs, so the eggs are not considered foreign. But the bad news is that the eggs, when they're ovulated, are ovulated into the abdominal peritoneal cavity, and in very, very close proximity, but not in direct contact with it. It's not a closed system. They're in the cavity. They're swept in by the mechanical action of cilia in the fimbriae, those tiny little fingers that you can go back and look at in the illustration, and there's tiny cilia. They create little eddies and currents of mucus and related material that rapidly draw the egg in once it's ovulated. Every so often it doesn't happen. So you can have an ectopic pregnancy, although rare, in the abdominal peritoneal cavity. The flip side of that is with that PID I was telling you about. When we have infections, and again, the vast majority are sexually transmitted, what they can, and they're gram negative mostly, is what they will lead into as they ascend their way up to the tube. And they basically, it's, I always say, it's a plumbing problem. They keep going back toward the ovaries, or in the male, back toward the testes. And what happens is they eventually get into the abdominal peritoneal cavity and cause peritonitis, and it becomes life-threatening. So again, directly into the cavity, it's an important distinction. Then the uterine tubes, fallopian tubes, oviducts, there's a zillion names for them, all the same thing, uterus, vaginas. Not a whole lot. This is where fertilization typically takes place, in the uterine tubes. It's about, from the entry point of the egg from the ovary, let's say a third or halfway toward the uterus. Okay, so the opening is called the infundibulum, the fimbriae, and the finger-like projections, and the cilia are the ones that facilitate the entry of the egg in there, and effectively in this ampulla, fertilization. Isthmus is where it narrows and it basically enters the uterus. Implantation of the uterus can be anywhere. Usually it's along the uterine wall. It's not that typically in the upper portion called the fundus, just like the name you have with the dome-shaped portion of the stomach. The dome-shaped portion of the uterus is called the fundus as well. So here it is. I'll tell you exactly what's going on with it. Nothing new under the sun here. And again, there's not a whole lot. This mesosalpinx. Salpinx is the name salpinograms, or when we used to inject dye. And I do not know if they still do them with today's modern technology, but that's what my first wife had done to make sure her tubes were patent when we were having infertility-related problems. And the same illustration is there. Nothing here is the fundus of the uterus, dome-shaped, implantate. It's all a giant smooth muscle, and the implantation generally is along the internal lining, which is called the endometrium. So the endometrium is the internal lining. The myometrium is this vast, strong muscle, and then you have the perimetrium is just really just a soft tissue outer cover. Everything else is pretty straightforward. Here's the ectopic. Big problems, bleeding, can be life-threatening bleeding. Here's the PID nugget. Oh my goodness. We saw so much of this. What I'm telling my students in micro, this was rampant back before, because in the age before we were made aware of HIV and AIDS. I mean, the late 60s and 70s were very little precautions were taken for intercourse, but no matter what kind of intercourse it was. It didn't matter whether it was hetero or non-hetero, or whatever type of intercourse it might have been. I think, imagine it was happening. That's it. Not a whole lot to say about that. Quick note, when you see it anteverted, normally it's over the top of the bladder. It tends or becomes somewhat retroverted backwards. In other words, it kind of is almost like sticking straight up, during arousal and eventually intercourse and climax. It facilitates the sperm entry. Just little side note, big player. I'll go over it in micro. It's terrible. Once you have this, you have this. There's no getting rid of it. Human papillomavirus is a wart virus. The problem is it's not. There's hundreds of different. Maybe that's a little bit over the top. There's probably the better part of 100 different types. A number of these types are associated with cervical carcinoma. It's not just in the female. It's also in the male, because the delicate internal area of the cervix is sort of mimicked by the skin surrounding the penis as well. So both men and women get these, what we used to call venereal warts, and they both have an association with cancer. Yes, it's more common in the female. It doesn't preclude the male not getting it. They used to be called condyloma acuminata. There are different names for them. They can be very problematic. The males, they can be all around the opening of the urethra and be obstructive. There's lots of stuff that goes on with them. This is the big problem. I mean, these statistics are probably from 8 years ago. We're looking at worldwide effects. Surely these days it's more than 500,000, probably the better part of 1 million, killing half. Most common cancer between ages 30 and 50 of this nature. Yes, we have the vaccine. I know it's not the purpose of this course to get into discussion of vaccines or whether it's not. Pap smears are extraordinarily important for those who are sexually active. You need to get checked. Whatever the appropriate recommendations are for your age group, and in consultation with either your family doctor or your OBGYN, I can't tell you how important it is. I'll say it again and again. For both men and women who are sexually active, particularly if you have more than one partner, you need to be aware and get checked on a regular basis. That's it. I mean, just do what you want to do in life. I'm not preachy about it. I mean, but be responsible in what you do. It doesn't matter what. It doesn't have to be about this topic, about any topic. Try to, like, I hope to demonstrate to you that I try to have a good time, and I'm irreverent about a lot of things. Like, I try to do my job well and take it seriously and be responsible for what I teach you. And hopefully be responsible to make sure you learn something. Not always successful, but I'm trying. And here, well, you don't know any of these ligaments or pouches, and who cares? And this is very prolapse uterus, very common. particularly women with multiple childbirths. The pelvic floor is just a series of muscles. It is very easy and overstretched, typically associated with childbearing. There's other risk factors. There's a wonderful unit at McGee. My late mother-in-law had surgery in her when she was in her 80s. You know, at least three. My wife has two siblings, so I don't know if that was the extent of her pregnancies, but it weakened the floor, and that tend to made predisposed her, which is a problem ongoing with urinary tract and bladder infections, and a lot of women have leakage. I know my mom had a corrective surgery for that years ago. She was about maybe, I'm going to tell you, my recollection, she was about 67, 68 years old when she had this. And my mother-in-law was probably past 85. So the pelvic floor unit at McGee is a very, very good unit. My mom had it done back in New Jersey. Here are the layers of the endometrium, of the uterus, rather. This is the big player here. Very important. We were going to get to it. This is where the fertilized egg burrows. There are two layers we call strata. Remember, from stratified squamous and stratified columnar, whatever. The layers are, it's a very, very, you have a layer of how else to describe it? A very thick lamina propria and then simple columnar epithelia that get larger, if you can possibly understand it. The way, from the description, it's not easy. It's not that you can't understand it. It's not, I can't describe it well. These two layers or strata have names. And because they're relatively large cells, and we have what's called the basalis. This is simple columnar that stays. The next layer, the functionalis, comes from the basalis. Whether it's estrogen or progesterone, doesn't respond to those. That's the basalis. Because all it does, its job is to produce a new functionalis. The functionalis was shed during menstruation. The functionalis is prepared and where implantation occurs. The functionalis plays a pivotal role, obviously, in the growth and development of the embryo and then the fetus. That's the whole ballgame. This is what it looks like. There's a lot of smooth muscle. This base layer or all sorts of columnar cells, they produce the functionalis. When you start to see these glandular-like structures, and you'll see the illustration shortly, that means it's ready for implantation. And also, it means if there is an implantation, this whole layer from like here to here is all going to be shed. That occurs. And it has to do with the blood supply, and it has to do with estrogen and progesterone, and it has to do with these two cycles intermixing each other, one called the ovarian cycle, the development of the egg, eventually ovulation, and eventually, following ovulation, implantation or not. In the absence of implantation, it's going to basically trigger the onset of what we call menstruation. And that involves understanding the menstrual cycle, which is basically the development of the functionalis, the preparation for implantation, and in its absence, now we have the blood supply. So effectively, these uterine arteries that come from the internal iliacs, they arch over the muscular portion of the uterus, and then they radiate in, and they form two kinds of branches: straight arteries that go to the basalis, and spiral arteries that go into the functionalis. The spiral arteries are the trigger. What happens, as long as we are consistently getting production of estrogen and mostly progesterone. In that part of the phase, after ovulation, progesterone is the dominant hormone. As long as that is but in the absence is being secreted, in the absence of implantation, the which we will go into, what's left of the enclosure of the egg, which has become a glandular-like structure called the corpus, which means body, luteum, which means yellow. So the corpus luteum, okay, takes over secreting estrogen, but mostly progesterone. If there's not implantation, it doesn't get a signal from the uterus to say the egg has been implanted, it begins to deteriorate. And it forms something called the corpus albicans. It's white alba, white body, and it's like scar tissue, and eventually it just deteriorates. At that point, with the absence of those hormones being produced, particularly the progesterone, it causes, whoops, as you will see, these spiral arteries, and now I can go to that, these spiral arteries will kink and spasm. Okay. They will, so here you can see the straight arteries. The spiral arteries will, what will happen is they will, when they say kink and spasm, they will just lock down. And what happens when it locks down is then you have no blood supply going here to this very elaborate glands and blood vessels and more blood vessels, functionalis, all ready to receive, and any part of it could receive the fertilized egg and what it's become as it's being undergone, several, how should I say it, several orders of reproduction of mitosis. At that point, when the blood supply is like that, it causes these layers to separate and they fill with fluid. And then whenever arteries are clamped down to, a pressure head builds up behind them. And then once the spasm goes away, then blood begins to flow, but at an increased pressure. And basically, now that there's a separation here, boom, it pushes it out. It's almost like the spasm created the weakness in what's holding the layers together. And when the spasm releases that backflow, that back pressure head of blood pushes it out. So what happens? You have a certain amount of tissue fluid, a certain amount of blood, and a certain amount of tissue. All of that is what we commonly refer to as menstrual fluid or menses that are there. It's not all blood. And understand, it's not a ton of blood, because I'll say it again and again, a thimbleful of blood will make a gallon of water turn red. You don't need a lot of blood. Blood's got a ton of hemoglobin, a pigment in it. It goes a long way. Okay, and the vagina itself, it's more, our organ is designed for copulation. It's the elastic nature of it that allows it to the typical male female copulation aspect. That, and I'm trying to think of the right way to sort of point it. It's the difference. What I point out to my other group, to my advanced physiology group. The reason there was so much trouble with HIV and AIDS in the gay male population is anal intercourse as a favorite product. Okay, it doesn't preclude other kinds, obviously, but the anal opening does not have that degree of fibroelasticity. It tears, and once you tear, you basically have compromised a boundary. And if in the fluid that is ejaculated, you have active virus particles, it gets into the bloodstream, and now you're contaminated. Okay, now you're infected with HIV and possibly are going to develop not just HIV but AIDS. Why it's less common in typical male-female intercourse is because the vagina is less likely to tear. It's designed to take those kinds of forces, without getting overly graphic about this thing. It's there. Other things that are there. The protection is acidity. In premenstrual or postmenopausal women, it's all about mucus. And then the childbearing years female, the menstruating female, is about acidity. That has to do with something called lactobacillus. Lactobacillus feeds aggressively on estrogen. Estrogen, on glycogen. The abundance of estrogen in the female reproductive during those years causes that female reproductive system to develop glycogen-lating cells in the lining, the lactobacillus, which are a very timid bacteria, but they gobble it up and ferment, and you get a ton of acidity that's there. But they're easily killed by antibiotics. That's the problem with why we see vaginal yeast infections. Yeasts are there too, but they're suppressed by all the acidity. Easy enough. And this is anatomy. This is part of the problem with people either doing self-induced abortions or having untrained people attempting to terminate pregnancies in that way. And it's a nightmare. It's probably why, at least in my opinion, why Roe v. Wade was enacted way back 50 years ago, however the changes are now, because people were, because of the illegal, and that's the argument, legal abortions, you're going to have less women getting gangrenous changes and dying and terrible infections from people who are unskilled or untrained or illegally doing abortions or trying to abort things themselves, versus what your feelings are about abortion vis-a-vis the ethics and morality, whatever you want to describe it. Not my topic to discuss. Always, because it's always a flashpoint. And really, there are other classes, ethics and philosophy, and different categories like that, in social classes. That's where you discuss those. I'm just giving you the facts. You do with them what you want. Moving on. Not doing any of that. Not the glands, or it's like the man has glands, has the bulbourethral glands. These are the vestibular. Used to call them Bartholin, capital Bartholin. All of these analogous structures, they're there. There'll be a question surely on one of those somewhere. And the perineum is the same. And again, you can see, if you go back and flip to the one on male repro, you can see the similarities. That's all I'm saying. And when we talk about the breast, understand that the mammary glands are basically, there's not a whole lot to them other than during pregnancy and lactation. They're probably an apocrine gland. Most authors agree with that. Milks to the newborn, but everybody knows about that. When we look at the female breast, that's in the post, the pubescent and post-pubescent and adolescent female, all the way to the adult female. It's mostly fatty tissue. It's there. It overlies the pectoralis major muscle. That's really the difference. I'm trying to think of the best way to express it. I mean, it depends. Why one develops in one form or another. I assume there's genetic bases for that, other than somebody who might be choosing to do it, enhancing it or choosing to alter it depending on whether they want whatever size is preferable, and for whatever reason that is. That's again not my area of expertise to discuss. It's there. We're not going to do this. So it's a modified Swift gland anyway, an apocrine gland. Ligaments are there, and so we only see these. The size is fat deposits, and the only changes have to do when there's, in non-nursing, the glandular structure really just goes back to being undeveloped. It's again significant problem. There's a lot of risk factors, as you can see here. All of these, and the reality is, the next slide you will see, the numbers are staggering. That's like 1 out of 6, 1 out of 7, 1 out of 7. It's probably more frequent than that. It's horrible. 70% without any risk factors. We know about the BRCA1 and 2. Most people are familiar. You should become familiar with those. I don't even think I'm going to ask a question, but you should going forward, because that's such a contributing factor, and that's why and everybody knows somebody, I suspect, who has elected to have, when they've had a cancer diagnosis, and these are found to be present, to undergo a preventative double mastectomy, and whether or not they choose to do reconstruction or not, that's their call. And you'll notice the risk for ovarian cancer. It happened to I tell everybody the same anecdote. It happened to I have a younger first cousin, his wife. They had 5 kids, and it's happened after kid 5. And I'm going to tell you, she had lost 2 aunts because of that. So it was in her family. She was raised by 2 aunts. I don't know what her mom died of, but the 2 aunts raised her, and they succumbed to this. So there was a strong family tendency, and when they discovered it in her, she elected to have the double mastectomy, and everything went fine procedure-wise. The problem was she was very slender, to a marathon runner and all that. I don't know if that contributed, but the problem was the reconstruction on one was satisfactory. The reconstruction on the other was awful. The constant infections took a long time for her to get better, a couple of years. Last time I've lost touch with her. Last time I think I saw her, I said hello formally, was probably at my mom's funeral. It's been 10 years ago. But as far as I know today, she's doing well. And the mammography thing, be familiar with it, etc., etc. I'm not going to ask any questions about it or any of the medicines. Done. Physiology. This is where I come in. That's noise for my next lecture. Very popular. Oh, oh, that was I just got an RMU alert at 1:36. Ongoing campus outage. We are continuing to monitor the situation as Duquesne Light works to restore power. Tell me there's no power. Moving on. I'm not going to do orogenesis or any of this stuff with you. I'm just not. I'm not. Yes, things that are noteworthy. The presumption is there's some speculation that there may even still be some egg production. Effectively, a lifetime supply. The estimates are about 450,000 between the two ovaries. They are produced prior to birth, and they're held at something called, remember, there's two phases of meiosis, meiosis 1 and meiosis 2. They're held in what's called meiosis 1. So they have not even completed the first, what we call meiotic division. So, I mean, once effectively what happens is one egg is selected, it develops, and what happens to that egg is it continues, it goes through, it completes the first meiotic division and starts the second, and it is then, at that point, it is ovulated in what's called metaphase 2, which means it has not completed that second division. It still is not, quote unquote, a true egg, even when it's ovulated. It's incomplete. It would not become a quote unquote complete egg until actually it is fertilized. The process of fertilization, if it occurs, will allow the egg to proceed to meiosis 2 and then complete meiosis 2. And at that point, the fertilization will complete itself, and we will have the formation of what's called the zygote. That's when the egg and the sperm unite, and those two haploid cells now form a diploid cell that we call the zygote. And at that point, that zygote is now the new cell that will become, assuming that all goes well and it proceeds to completion, the male or the female is going to develop into. And then at that point, no more meiosis, it's all mitosis. That's the way I can summarize it. So this one follicle that is selected, okay, the follicle effectively is the enclosure. That follicle, once ovulation occurs, effectively that becomes the corpus luteum. That, what I mentioned before, that's going to produce all of those hormones. And I'm worrying about pregranulosa because some of these granulosa cells are going to be part of the follicle, and we call these, and we're going to not getting into primary follicle or any of these primordial or primary or secondary, etc. There's a number of these things. What's interesting is when whatever follicles that becomes the primary follicle, a number of them are selected, but really only one. A number of them are activated, would be a better word, but only one really becomes the primary follicle. Okay. And what will happen is that will be the one that undergoes development at the start of the what we will see very shortly is the ovarian cycle. It continues on. And when we know it is matured, at that point it develops what they call an antrum. That's an area of fluid that's eventually going to surround and protect that egg for a certain amount of time as it's being ovulated. So it's a large vesicle. So we call it an antral follicle or a tertiary follicle or a vesicular follicle. There's a number of names. Years ago, we used to call it a Graafian follicle, capital Graaffian. And because we began to see the fluid, and you'll see some of the illustrations of it in a bit. And here's this is just an illustration of it. That's what it becomes when it's ready. So here you're in meiosis 1 still. When it's activated, again, we still haven't even completed the first meiotic division. Once it's ovulated, and you can see that enclosure, the follicle that remains, okay, is what's going to become this corpus luteum. That's what's going to take over the production of estrogen and progesterone for the duration of this cycle, okay? And we'll continue to do so. If there's implantation, it will do it for 3 months. If there's not implantation, it will do it for only 10 days. And at that point, it will effectively lose its function. It'll deteriorate. It'll become something called the corpus albicans, which you'll see shortly. And eventually and it's that transition after those 10 days that leads to the process we call menstruation. So in the event, however, so we're now at that stage. Okay. In the event, here's what we will see here is the next stage. If the sperm is able to penetrate, if fertilization occurs, then that will then complete. It will go from being still suspended now in metaphase 2, means that metaphase is the second meiotic division. At that point, if once it's fertilized, it doesn't mean the sperm has finished created a diploid, but it will do so shortly after. And once it does that, that'll be the completion. The fertilization will take place almost simultaneously. And these are called the polar bodies. They're small and they deteriorate. But as you can see, the vast amount of cytoplasm, that's why all of the organelles come from the mom. You hear about testing for mitochondrial DNA to identify somebody, you don't get the whole picture. It's not like doing DNA for paternity testing. Okay, you're only getting mitochondrial DNA is something where you're basically going to see if it's a, a sibling, a family member, some degree of relation, but you won't tell the whole picture. As you can see, fetal period, primordial follicles first develop. So the primary oocytes are arrested in prophase 1. That's what I told you before, and only a small amount. And generally, they go from side to side. Everything else undergoes apoptosis. Okay, and so as the ovulation each month, the high levels of FSH, follicle stimulating, selects, but effectively there's a group of them that are there, but that becomes the dominant follicle. That's the one that develops. And we covered all of this. And so what you have here, this large cell with all that cytoplasm will be enough to nourish it for roughly, and it takes about a week to get to the uterus. Okay. And again, this is everything is being, the whole idea is this is a sequence of events that occur because the goal of the exercise is fertilization, is fertilization and implantation is, and anything else that happens is, and if it does not, then we lead to menstruation, so to speak. So, and these are different things. Okay. I'm not too concerned about that. Oh, as you can see, ends in menopause, even though the eggs start during the fetal life spermatogenesis, we talked about that before, doesn't start till puberty. Not worried about the error rates, not worried about all that stuff. You can see the numbers are unbelievable in the male. How many sperm that are there. All those things are interesting, but none of it's really that critical for us. And so this is just, you don't have to worry about the different gonadotropin and independent hormones and all of that stuff. Eventually, what it will lead to is the formation of this. So here you're beginning to see exactly, this is that, what they call the zona pellucida is a protective layer around it, around what's called the secondary oocyte. And when you begin to see that vesicular area or antrum, that is able to the fluid exerts a force against a weakening ovarian wall. And that ovarian wall is weakening, and you'll see it weakens because of a surge of luteinizing hormone. We call it the luteal surge, a big surge of LH. And then it's ovulated and we proceed. So that primary follicle eventually becomes a secondary, and I'm not worried about the thecal cells. And then secondary becomes that so-called vesicular follicle, and you saw that large cavity of fluid, and that's what distinguishes it. And that antral phase is just the precursor to ovulation. That follicle is now pretty good size, can be considered something. Most of those things we are looking at are microscopic. I mean, maybe about an inch for the follicle. Understand the egg will be smaller, and it's ready to be ovulated. And again, after the oocyte and this protective area, which also has a name, corona radiata, like a structure in the brain, they have nothing to do with each other. What's left of that is the corpus luteum, and that luteum will take over the role of estrogen because the ovaries will no longer produce those. Okay. And really, that's where birth control pills came from. Effectively, as long as there's levels of FSH, a bigger part of estrogen and progesterone being produced, the signal doesn't go. It doesn't go back to the hypothalamus and to that arc we talked about, to the pituitary, and say, "Oh, we better get a jolt of FSH and LH, which we better get ready for the next ovulation." That's what stops it. So what birth control pills did initially, what they do now, I don't know, or if they're formulated similarly, I don't know, is effectively you're paying what we call a metabolic trick on your brain and saying, "Hey, I'm pregnant," even though you're not pregnant, but you're basically using chemicals, naturally occurring chemicals to tell the brain otherwise. Which brings us to 2 cycles. And because my voice is dying, I'm taking a break. So I'll get back to you with more shortly. So thanks a lot. Bye bye.